he is going to present the today's topic. And
Hi, Dr. Pramod. Hi, nice seeing you.
he is Dr. Manish. He is from FMRI Fortis Hospital, Gurgaon. He is one of the leading ECMO practitioner there, consultant working in Fortis. And actually, he has taken a lot of classes for us, also organized a lot of sessions. So that's why we invited Dr. Manish. And with us, Dr. Harsh. Dr. Harsh is from Hyderabad. So he is basically working in KIMS Hospital. And he also has lead a team of ECMO specialists, and they have also done a lot of ECMO cases. So yeah. So basically, Dr. Pramod is the senior consultant. He's the ECMO in charge, and he's the leading ECMO consultant in Mayo Clinic. And he's basically MBBS, MD, DM, and he has also a lot of research publications. And I really thankful to him because he has given his valuable time and to organize this session. So I really appreciate his efforts. And we'll starting by 6 o'clock. Why it is okay?
Yeah. Thank you, Guru, and thank Dr. Chauhan and Dr. Harsh. I'm scared now because you guys are.
No. I think that all of us, I believe in ECMO, we are still learning a lot. I was telling Dr. Puna that I think I'm the wrong guy for this session because I am done a lot of ECMOs, but ECOR is not something that I'm into. Partly because
I think.
But yeah.
So let me introduce Dr. Achilles. Dr. Achilles is my colleague. So he is working as a consultant, means a consultant intensivist in Apollo Hospital, Navi Mumbai. And basically, from long time we are being associated. And this academic event is one of his brainchild, you can say. And he's very much academically oriented. So, Dr. Achilles, your video, please. Achilles, your video is. I think your video is not working. Achilles, are you there?
Yes, I'm there. Just find a suitable place.
Yeah, so please log into your video, na?
Hi, Dr. Achilles. Don't be shy.
Dr. Chauhan, where do you practice? You practice at Delhi?
Yeah, in Gurgaon, Fortis Gurgaon.
Oh, Fortis Gurgaon. And Dr. Harsha, where do you practice? Hyderabad?
I'm at KIMS Hospital. KIMS Hospital, that's in Secunderabad.
Oh, okay.
It's the same one you're with the Dr. Towers team? Where Dr. Tower works?
Tower, yeah. That is a HLT team. That is a heart-lung transplant team. We have
our ECMO in 2014 with Dr. Tower only. So along with the CQS team now, we are from the CCM team. So they used to support us and the surgical background. Dr. Tower and the perfusionist used to be their head lead perfusionist.
They do a lot of bridging ECMOs and HLT as a part of HLT. We also have a second unit as a part of medical ICU. So we have a second unit that is my colleagues are also there that are actively into that basically. And we have a second team as well that is headed by the HLT.
Yeah, Dr. Prabhat and Dr. Tower, we started off together.
Yeah.
So I think I'll just give a brief background of this today's session. So first of all, in 5 minutes we'll start, and to begin with, I'll just have a basic idea about the therapy for the ECMO and ECOR, and primarily we'll focus on the extracorporeal CO2 removal as the today's topic is there. And I'll just have a 2 to 3 minutes summary of why there is a need for discussion of this topic. And then I'll introduce all the panelists. And after that, Dr. Pramod Guru will start the session for all the delegates. And followed by, we have a panel discussion where we'll take the questions from the delegate in the chat box. And I'll also ask, and my colleague, Dr. Achilles, will also have some discussion with you regarding few of the important aspects of the ECOR. So this is what the overview of this session. So hopefully it will last for around 1.5 hours. And we'll try to finish it early if it's possible. And in 2 to 3 minutes, we'll be starting. I think the other panelists have just logged in. He is Dr. Subhadeep. Dr. Subhadeep is working as a consultant with us in Apollo Hospital, Navi Mumbai. And he's also an ECMO trained. Basically, did his diploma from the ECMO from La Piti Hospital. And so with this, we'll starting in 2 to 3 minutes.
Hello, welcome everyone. Welcome,
Hi,
Dr.
Dr.
Gunnar.
Manish. How are you?
Hi, Dr. Munish. Welcome after a long time.
Long time.
Maybe almost
COVID times.
3.5 years, I guess.
Yeah. I think the last time you
Yeah.
were for an ECMO course only there. We had that.
Yes. How can we forget those days? We had to rush back for our heart transplant. We had come for the ECMO conference.
I remember.
We had to rush back for the heart transplant that was going at our
So I think the
hospital.
first heart transplant that was.
Yeah, that was the first heart transplant at our place. Yes. So how are the things going on?
It's good.
COVID?
is not there right now. Non-COVID, a lot of cases.
Okay. So yeah, we have other panelists also and moderators.
Yeah. So I think without wasting much time,
Yes, we'll start.
We'll start in 1 or 2 minutes. I think let's wait for 1 or 2 minutes, then we'll start the session.
Yes.
So Dr. Pramod sir, are you able to upload your PPTs and you have already checked? So I don't think it will be.
Yeah, that's what I was just trying to get you. Should I show that or maybe? Let's do one thing. Okay. Can I share my screen?
Yes, please.
Are you able to see?
No, not right now.
Okay.
Welcome, Dr. Pramod.
Hi, Dr. Akhilesh. How are you, sir?
I'm fine.
Nice to meet you, or maybe
Yes. Thanks for coming.
Guna.
Yeah,
I don't know.
We are not able to see your PPT.
Oh, that's what I'm saying. So let's share screen. It says that the host has disabled participant screen sharing.
Okay, wait a minute. Why can you this thing or should it?
Because who is the host? If you
see, the thing is that I will make you the host, but then you have to admit the people also.
You cannot. Okay.
Or second thing, you just send me the PPT to my mail ID, or.
So who is the host? Are you the host?
No, Misbah. Misbah is our coordinator. She is the host.
Oh. Okay, then ask. Can she do that?
Yeah, she can.
Okay, because I believe the PowerPoint will take time to reach you.
I think screen sharing will be good enough. You can just do a screen sharing. Anybody can do it.
So it's
actually, Dr. Gunadhar, if you can just enable the screen sharing option.
Yeah, when I click the share screen, it says that the host disable participant screen sharing.
Yeah, in that case, Misbah should do that enable the screen sharing option.
Yeah. Okay.
Sir, I think we are making you a host. now you can share, but you have to admit people also in between. Just admit.
Okay. So is it coming somewhere? I have to admit.
Yeah. It will come as a pop-up to your window.
Oh,
Just you have to keep on clicking that thing.
I will do that. What about right now? Are you able to see?
Yes.
Okay. And then I will go to the, what about right now? Which one you are seeing? Is it the full one or with the side to side?
No. Both full one and side to side.
Oh, how do I disclose the side to side then?
Yeah, I think it's good enough, but only thing you have to make it in a PowerPoint mode.
Yeah, what I'm saying is I don't want.
Okay.
Are you able to see?
Both.
For both one?
Yeah, both one.
How can I change that? Okay, let me see. More slide slow option.
I think so. In the more slides show option, just select hide the presenter view.
Hide the presenter view. Okay. Is it okay now?
No, that ended the slideshow.
What's that? Did it come okay?
Yeah, but it's not visible in the PowerPoint mode.
Oh, okay. If I go there, then I go here.
Resume slideshow on the top. There's an option coming.
Or resume slide slow. Is it coming good now, Dr. Munish?
No.
So let me stop sharing, then I'll go back. PowerPoint slides. So. Mispa has said something. Okay, let me. Okay, so if I go here, share screen. Okay, what should we? Is it good now?
It's same only.
It's same. No changes.
No.
Mispa said something. Go to slides so next to the animation.
You can just go to the display settings in the right upper corner, right left corner, and then change it to that.
Change to swap present view and slide. Is this okay?
Yeah.
That's perfect.
Yes, that's good.
Okay.
Thank you.
Good. Okay. Sorry. The technique all the time. Okay. Whenever you are ready, I'm ready.
Yeah. So in between, you'll also get the invitation from the the upcoming delegates. You just have to click yes to admit the new delegates, because you are the host. So they will ask your permission. So just that you have to do, because our coordinator is not actually not able to make the co-host. So that work is up to you to admit people. Will it be okay for you?
Yeah. But it's not showing me where it's coming. It's so that 8 people entered the waiting room. So
just Misbah, how can you can click yes to the waiting room? Can you just?
I admitted all.
Yes. Fine. Like that only. Yes. Now they are coming. The delegates are joining. Yes. Fine.
Okay.
So in between. So anyway, I'll just start the session, and then I'll hand over to you, sir. Okay, so welcome you all.
आणि एक आहे की नाही त्याच्यामध्ये तावा तावाने भांडे
So welcome you all to this academic session of extracorporeal CO2 removal. So basically, why there is a need for this talk, I'll just 2 to 3 minutes I'll describe. So what is the need for the ECOR basically? So ECOR is a device which can remove the carbon dioxide, and basically it reduces the stress and strain of the lung. It also controls the hypercapnia and its potential harmful effect, support and may accelerated weaning in hypercapnic acute respiratory failure of the patient. So if you see the burden of the ARDS in any of the ICUs is very, very large, because the studies has also proven that, like the lung safe study, which is done by the ESICM trial group, it's a large observational study to know the global impact of the severe ARDS in 2016. That study published, and it has taken into account almost 50 countries with 450 ICUs, and they have enrolled 3,000 patients, where the ARDS remain one of the under-recognized and under-treated entity. And that is the reason that is the need of the time to discuss every possible treatment therapy for the ARDS to improve the patient outcome. The period prevalence of ARDS in that study is around 10%, and almost the mortality is in the range of 36%. And they have found out that hyperinflation and high driving pressure are the two important predictor of mortality in that study particularly. So if the driving pressure exceeds more than 14 centimeter of water on the day first, the patient usually had the worst outcome. And obviously, the increased PaCO2 and decreased pH is also associated with an increased ARDS severity. So that is the reason there is a potential role of this ECOR to remove the carbon dioxide, facilitate the lung protective ventilation. And of course, we can say this is a ultra lung protective ventilation strategy, which could be facilitated by this particular device, which is called the ECOR. And the ARMA trial, or so sometimes called as the ARDS network trial, also published in 2004, almost shows the same thing. And they have clear-cut shown that ventilating with lower tidal volume definitely improve the outcome in any of the ICUs. So, and that is the reason the Italian investigator Gattonini, when he did the CT scan of the lungs with patients with low tidal volume ventilation, almost he found out that 30% of the patient with lung protective ventilation strategy had symptoms or had hyperinflation in the CT scan. And to decrease the hyperinflation to the lowest possible tidal volume should be achieved. And in the context of achieving the lowest tidal volume, what happens basically, we increase the respiratory rate because the carbon dioxide goes high. So if there is a device which can eliminate this carbon dioxide, that will definitely facilitate the ultra protective lung ventilation strategy. And this is the biggest study, I think, the RACE study, which is done in all across the European centers. And they have compared the ECMO, the ECOR versus the standard therapy. Obviously, this is a negative trial, but this is one of the landmark trial, followed by the Supernova trial, which also shows that the ultra lung protective ventilation strategy can be achieved with your ECOR therapy. So that is the reason this is the role of ECOR in the ARDS, but our main aim is to discuss the role of ECOR in the something called as non-ARDS group, like patients with severe bronchial asthma, patients with COPD, to facilitate the weaning, or can we prevent the ventilation when the patient comes with decompensated COPD by use of the ECOR? So that is the point of discussion. So with this, I hand over the mic to Dr. Pramod Guru, and I'll just introduce Dr. Pramod Guru has done his DM and DM in nephrology and critical care, and he is heading the team of ECMO and critical care in Mayo Clinic, the United States of America. And he has done a lot of ECMO cases along with the ECOR cases. So he's the best person to guide us. And I hand over the mic to Dr. Pramod Guru.
Thank you, Guna, for your time and the kind introductions. Thanks all the participants for your time. My name is Pramod Guru. I'm originally from India, but somehow I decided to come here and has been here in Mayo Clinic almost close to 8-9 years. The topic of today's discussion is what is the role of extracorporeal carbon dioxide removal in management of hypercapnic respiratory failure. I do not have any disclosure. However, I can say that I am a strong believer of ECMO, the reason being many. So we all have our story because before we accept something, whether it is medical literature or fiction, everything what we do, we all have to believe on something. So somehow I became a believer of ECMO during my critical care training at Rochester back in 2013. And since then, so far. So the objective of this talk is that by the end of minutes, we are discussing what are the implications or why we should remove carbon dioxide, what are the configurations of the circuits which has been utilized in the current practice, and what are the novel things coming up, and is there really evidence for utilization of this technique in the management of hypercapnic respiratory failure, and then what are the problems we are facing while managing these people. So as Gunnar nicely pointed out, there is an unmet needs for bringing something to the bedside and help the patient, those who are really requiring our attentions. And I would say that they are the sickest of the sickest people in our hospital at a given moment. So what is the unmet need? The unmet need is that, as he pointed out, if you all probably enter to any hospital across the globe, in particular the ICU, almost probably all of these people are in mechanical ventilator. And this is the long SEP study, which was published a couple years back, almost 50 different country with 460 ICUs. They find out that at a given moment in the ICU, there are almost 10% of people have a diagnosis of ARDS. And depending upon the classification, which is the Berlin classification system, on that, the distribution is that more than almost two-thirds of the people are in the moderate to severe category. And then mortality in these people is definitely bad. When I say definitely bad is because 50% of the people do not survive to leave the hospital at any time. So whatever we do, because this is the problem. So the problem is we don't have a treatment for ARDS. What we have is the support system. The support system is nothing but the mechanical ventilatory support, which has been possibly trial and studied and practiced since 1950, since the pandemic of polio. And then that helped us to develop this concept of ICU and intensivist and then critical care medicine. And as all of us coming out of this, probably, I hope this is the once upon a lifetime experience of going through the pandemic and then COVID-19 pandemic. So the COVID-19 pandemic, despite the primary process for which people really died or suffered, or maybe you can say that they didn't really get the appropriate care process, is the difficulty in managing the ARDS patient, because there is no treatment. You have to treat the primary process. This is a so-called stepwise management approach for the people, those who have ARDS, if they hit your ICU. There are many strategies, as you all can see that, and that is also in the middle, it is written extracorporeal carbon dioxide removal. So we need to realize what is the role on that. So, if we goes back to the current theory or the practice of ventilatory management in the ARDS patient, it's all changed back since 2001. It's almost close to 2 decades. What happened at that time? The ARDS net trial was published. The prior practice where there are 12 ml of tidal volume versus 6 ml, that was the trial, and it changed the entire practice. What was seen that there was a significant or more than 30% reduction in the mortality. So everybody adopted that practice. But is it really true the real world scenario, this is from the long step study. You can see that even more than 1/3 of the people at today, they are also getting higher than 80 ml per kg of tidal volume. And that is also the plateau pressure, which is being considered as a measure that you need to reduce or have the plateau pressure close to 30. This is not in measured more than like 60% of the people. And the other one is that we all knew that for the management of ARDS patients, we have to have a optimal PEEP. The definition of optimal PEEP by many guidelines is close to, I would say that close to 16, but you see that almost 80% of the people are managed with less than 12 centimeter of PEEP at a given moment. So the question is like, why this is happening? I don't know what you all are thinking, but the thought process should be directed towards the topic of our discussion. What we have to think is, what is the barrier for adopting the lung protective mechanical ventilations at the bedside in a particular patients, particularly in ARDS? There are many. So one of the things is possibly is the reason why we need to think outside the box and possibly bring the extracorporeal carbon dioxide removal technology to the bedside. Guna pointed out a nice strategy that, we all are following or maybe adopting the lung protective mechanical ventilation strategy, which is being studied by the ARNS protocol. But I would say that this is not all inclusive. Even if the 6 ml per kg of tidal volume has shown that it improves the outcome as well as the plateau pressure of less than 30, but how do we know that? Is that the absolute number? Why cannot it will be 5? Why cannot it will be 4? Why cannot it will be 3? Why cannot it be 2? Or maybe 0 almost? And then same with the plateau pressure. Where do we draw the line for the plateau pressure? Is it 30 is the absolute? Can it goes down to maybe less? So that brings to the question of what people are pointing or maybe proposing since last 3 to 4 decades. It's the concept of ultra protective mechanical ventilation. Protective mechanical ventilation, by definition, we know that because you reduce the tidal volume from 12 to 6. And we reduce the tidal volume more than
I request everybody to please mute their system.
So
You can mute everyone from your side, sir. Just press the mute for all.
Oh, okay, got it. So okay, this is done. So the idea of reducing the tidal volume in ARDS care is primarily focused on reducing the ventilator-induced lung injury. But what's the problem? If you reduce the tidal volume, there is two main things. You are decreasing the minor ventilations, and there is alveolar decrement. That's not favorable at the bedside for the patients as well as the machine as well as the physician group, because it will create the problem, which is mainly the difficult gas exchange with worsening hypercapnia. And that's the primary reason why the people are not able to really adopt the ARDS net protocol at the bedside. The next problem, which is primarily focused as the COPD. We all knew that this is the 4th leading cause of death, and this is being proposed by 2030. It will be topping into the 3rd, the primary cause of the death, besides many other. And most of this death happens in the low or middle income country as compared to the high income country. And then the practice is defined that non-invasive ventilation is the gold standard for COPD care whenever they hit the hospital with acute exacerbation of COPD, either because of the infections or the primary inflammatory process, and you need to give the antibiotic and give steroids and go for NIV. NIV is good. It's not only help in the COPD people, it's also very helpful in acute pulmonary edema secondary to heart failure. And there are some signals that it might be helpful in people, those who have immunocompromised and they have respiratory failure because of many reasons. How does it help? It has two important outcome measures, which are patient-centric and is very robustly studied from multiple trials, both the RCT as well as prospective studies, that it reduced the short-term mortality and is also reduced the rate of tracheal intubation. Again, we all knew that this is gold standard, but what's the practice? What's the problem? The problem is 1/3 of the people, or maybe half of the people with NIV, on those who are coming to hospital with hypercapnic respiratory failure because of the COPD, they failed NIV. And when they failed NIV, the only option at this moment is available to us is put them on mechanical ventilator. And if you compare the group, those who are failed NIV and going to the mechanical ventilation versus only NIV and managed, they are like prone to have more complication. Their mortality is higher. They have more barotrauma, polytrauma, you name it. And it's obviously the elephant in the room is mainly the mechanical ventilator. We all knew that though mechanical ventilator helped or has been helping thousands of people and also changed the paradigm of medicine practice across the globe for last 7 decades, they're not really friendly. Why? Because we changed the natural way in which we breathe. Naturally, we breathe a so-called negative strategy, but the positive pressure ventilation gives or force the air to our lungs. That's what's the problem. And then the surrogate indicator of the positive pressure ventilation, which really translates into all complications in the ventilator-induced lung injury. So that brings to the questions, why we should consider. So that means, what is the rationale for extracorporeal carbon dioxide removal? So before we jump into that, we'd like to know some of the physiological as well as practical problems. The first question is hypercapnia really a friend or a foe? That means, does really hypercapnia help? We know that ARDS net protocol says that permissive hypercapnia is acceptable and may be allowed if there is an oxygenation problem in patients with ARDS. And we all knew that in patients with COPD, sometimes despite the best effort, we may not be able to achieve the normocapnia, and sometimes we become comfortable with that. But what is the real problem with hypercapnia? The real problem with hypercapnia are many. In the ARDS group, it has been shown that the primary factor for which you cannot adopt the lung protective ventilation is because of the hypercapnia. And this is one of the studies just I have showed that like 2,000 people, those who are in mechanical ventilator. So each increase, 10 units increase in the PCO2 from a cutoff level of 50, the odds ratio progressively increases. So when you hit the number almost 70 or more, there are 3%, like the odds ratio of having a problem related to hypercapnia or mortality is almost 3. And then it also been like, as in the mention, that it is independently associated with higher mortality in the patients with ARDS. And that is also true for COPD patients. How does permissive hypercapnia is helpful? It is being said that if you accept the permissive hypercapnia, possibly you are going to achieve more oxygen delivery and possibly the forward flow, because the oxygenated blood is going to the rest part of your body, and then all the organs will be delivered by oxygenation. You just bite the bullet and keep happy with the hypercapnia. But the problem is hypercapnia does very bad things. One, it increases the RV afterload and it decreases the RV contractility. It's impaired pulmonary epithelial repair. And then the other thing is it has been shown in the both animal model and some of the anecdotal data, or maybe I would say that some prospective studies on the humans, that it has immunosuppressive effect. By that, it increases the risk of infections. And the most common things we all knew, that it is not good for raised intracranial pressure because it's not going to help your brain at all. So that brings to the physiological aspect of the hypercapnia. How does hypercapnia or the carbon dioxide is staying in our body, and how does this extracorporeal removal helps? The way it is that the carbon dioxide is different from the oxygenations. Oxygen has a sigmoid saturation curve. However, carbon dioxide is a linear and steep dissociation curve. The most important factor which is helpful to really extrapolate the physiological aspect to the extracorporeal removal of carbon dioxide is the higher solubility of the carbon dioxide, which is 20 times higher than the oxygenation. But the problem is carbon dioxide in the blood usually not stays in the gaseous form. It is dissolved as the carbonic acid and bicarbonate. So in order to remove the carbon dioxide, this has to be break down by somehow. Without that, it's difficult to get the carbon dioxide out, because the dissolved percentage is only 10%, and the very minimal percentage is carried out by carbon dioxide, bind to the RBC. So because of this physiological restriction, I would say that why we are facing the problem of really like having a happy role of extracorporeal carbon dioxide removal in the care of the people at the bedside. And I'll come back to that as we move on. So that brings to the next question. What is the principle of extracorporeal carbon dioxide removal? As you all knew that extracorporeal by definition means that you are bringing the blood outside the corpus. That means you are bringing the deoxygenated and like hypercarboxylated blood from the body. Then you are putting that blood in a machine and then decarboxylating that blood and then returning back. How it is different from the ECMO? In the ECMO, what we do is we are taking the blood, we are oxygenating it and then giving back to the blood. If we return it back to the venous side, then it's called veno-venous ECMO. If you return it to the arterial side, it's veno-arterial ECMO. And we all knew that each of these forms has a different aim and goals. VV ECMO is primarily support your lungs, and VA ECMO support both and heart and lungs. In the extracorporeal carbon dioxide, the beauty is that it does one thing very nicely. With a lower blood flow, most of the times the available machines goes up to 1.5 liter. With the lower blood flow, you can take out the carbon dioxide pretty quickly. You do not have to have a high blood flow, which is required for oxygenations. And then the benefit of that is you can reduce the hypercapnia in the patients with ARDS. You can avoid the intubation in a COPD exacerbation patient, as also possibly decrease the duration of mechanical ventilator in patients, those who have a failure of NIV. So this is what the basics principle. And then, as all of you probably know, that there is many methods you can do, but the simplistic circuit component, you put a large cannula. Here, the cannula in extracorporeal carbon dioxide circuits are usually smaller than the VV ECMO or VA ECMO, or 13 to 14 French, like little bit larger than the dialysis catheter. You take the blood from any vein through a pump and then goes through the oxygenator or membrane lung and return back to the venous. So the main factors which are responsible for carbon dioxide removal in the machines are mainly three. So one is the diffusion gradient of the diffusion gradient of the carbon dioxide across the membrane. Number 2, the contact time, how long the blood is in contact with the membrane, and then the most important thing, how much blood is really flowing. So these are the main things. And the last not but the least is the flow of gas. We call it sweep gas. It's similar to VA and VVA. So that's what's really dictated. The major factor is the diffusion gradient as well as the so-called the contact time, and then there are many others as you all can read on this the slides. I'll share it with Gun after the talk. So what are the types of ECR devices? So if you think about, there are many. However, the primary device which came into the market and still used but less frequently than before is called the arteriovenous devices. The second one is veno-venous. The third one we call the respiratory dialysis. The fourth one, they are still experimental. That's called gas exchange catheter. I would say that all these devices are being utilized, but the bottom line is they are still being considered experimental because of the many reasons, as we are going to hear and see in the next couple of slides. These are the players in the market. That what I'm trying to say is that this is what available for us in the United States, but that's also many modified forms are available across the globe. And the AV devices, what is the beauty of AV devices is that it has no pump. The problem with the device is that you need a minimal arterial gradient, the AV gradient. So that means your mean arterial pressure in the patient should be at least 60, and some people say that it should be at least 80. The way it's that, as you can see in the picture down there, you put the cannula, the venous cannula on the femoral vein, then you have this oxygenator, and then the return cannula goes to the femoral artery. So your mean arterial pressure is the primarily responsible for moving the blood through the venous, through the oxygenator, and coming back. So obviously, if your patient is hemodynamically unstable, like many of these people, those who come to the hospital with hypercapnic respiratory failure because of acidosis and then myocardial depressions, and you have hypotension, you cannot utilize these things. The prototype is called Nova Lung, and then the maximum blood flow depending upon you like how good is the catheter and what is the mean arterial pressure is varies. The other thing is there is no heat exchanger, as you all have seen in the VV or VA ECMO, there is no heat exchanger. The main problem with this device is, as I said, that the limitation is the mean arterial pressure. You have to have a certain, you have to add inotropic support to maintain the mean arterial pressure, and because the catheter is going to be placed in the femoral artery, then there is a potential risk for bleeding and ischemia, many other things. So what are the VV system? They all have a mechanical pump because that's what it generates the negative flow on the venous side, brings the venous blood to the membrane lung and then return back. There are many types. Then again, the blood flow varies depending on which prototype we are all using. There are many consoles. One is a single console with combination of the membrane as well as the filter. The other have separate. So the other advantage of VV device is that they can certainly provide some oxygenation, but they are not great. If you compare head to head, the biggest difference between VV ECMO versus extracorporeal carbon dioxide removal is the ability to support oxygenation by VV ECMO, which is not the case with extracorporeal carbon dioxide removal devices. What does that mean? If you are thinking that your patient has problem with both hypoxemia and hypercapnia, and you cannot be happy with the hypoxemia, then do not think about extracorporeal carbon dioxide removal devices, because that's not going to help you at all. So that brings to the next thing is what is called respiratory dialysis. By definition, as it says, that it's a dialysis because you are removing bad product from the blood. In this case, is carbon dioxide. It is respiratory because carbon dioxide is primarily exchanged in the normal lungs through the lungs. So the concept is a little bit different, because what has happened, it's the technology in which carbon dioxide is removed in the form of bicarbonate, not in the form of carbon dioxide. So why this is coming, or why people are very fascinated about the removal of carbon dioxide in the form of bicarbonate, because of two things. One, we know that hemodialysis, when we are putting bicarbonate based dialysate across the membrane and patient has metabolic acidosis, there is the exchange of bicarbonate across the membrane, and then the acidosis get clears. So the concept is that if we can do something, let's, instead of a bicarbonate of 20 on one side of the membrane in dialysis, if we can make the bicarbonate to 0, and then probably ask the diffusion crossing the membrane, then we'll achieve the goal of removing the carbon dioxide. So that's theoretical possibility. It sounds pretty physiologically nice, but practically it's not possible, because there is a diffusion restriction as well as conversion problem, because of the because that carbon dioxide remain in the blood in the carbonic anhydrous state. So it has to somehow break down quickly while the blood is passing across the membrane, and then the diffusion has to also occur adequate so that the patient can be benefited. Because of this logistical issue, there are practical problems. People have tried to bypass that, how we can achieve this goal with some other methods, like, replace the bicarbonate with sodium hydroxide or tromathin or organic anions. But, like, we did try it in a couple of our patients in the ICU. We all face this problem, to be honest. Fluid gain, hyperchloremic acidosis, hemolysis, they do have many arrhythmia, and acid-base diarrhea. It's very difficult to really handle the situations at the bedside when you approach that concept in day-to-day practice. But there are many. This is called the respiratory hemofiltration. If you read the literature, there are many ways, and more coming into the market. One of our colleagues from Mayo, Arizona, I think I have that, maybe in the next one also. So the other one, the last not but, that's called the gas exchange catheter. What is that? Is here they tried, or these are all experimental. Here the catheter goes into the IVC. The machine here, you can see that the balloon inflate and deflate. They suck the blood to the catheter, and then there is the oxygenation as well as carbon dioxide removal process. But they are, they are very, very primitive at this time and not being utilized any of the patients currently. They are all experimental right now. So yeah, this is what I was trying to later. This is a respiratory electrodialysis concept, which was done by our group from Mayo, Arizona. Again, the take-home message from all these things that these are the process which can help to bypass the restrictions because of the carbon dioxide staying in blood as carbonic anhydrous. But we have to go a long way before we can do something. So that brings to we all know that now, what are the physiological problem, what are the practical aspects, we have to really be careful. And then, did it really matters? Because at the end of the day, we can learn a lot of theory, but in the practically, if we cannot help the patient at the bedside, it doesn't matter like how good is the physiology. So the rationale for the ARDS patient is to decrease the intensity of mechanical ventilation. Since we are not able to provide so-called lung protective mechanical ventilation strategy, then we need to find out the alternative, and extracorporeal carbon dioxide removal technology is possibly or should help to reduce the carbon dioxide and facilitate the lung protective mechanical ventilation, and maybe help us to achieve so-called ultra protective ventilation strategy with lower tidal volume than 6 ml, and it should help us to reduce the plateau pressure below 30. So how does it really work? The concept is not new because it's been there since 1970. Gattinoni, who is still alive, and gives nice talk about that. He promoted this concept of apneic oxygenations, which is the like so-called surrogate marker of otherwise called the decarboxylations in these ARDS patients back in 1970 when he went with his group and do the trial back in 94 with the, but this trial is almost like stopped or completely take a negative mindset in the practice people that it doesn't really help. In that trial, there are the need for transfusion was very high. All these people have in the advanced stage of their disease process. So then it was very resource intensive. But things have changed since 2009 for all of us, as you knew that how the ECMO practice has really grown to the extent that it should be considered pretty normal in all ICU right now. And then the pandemic, at least the COVID-19 pandemic, has done one thing definitely, in my opinion, is that it is established the fact that we need to bring more form of extracorporeal therapy, whether VV, ECOR or VA, to the bedside, and it should be included into the all ICU algorithm. That's my take, but again, it's a big take, but this is what it is. We can definitely save many patients if we select appropriate patient at a particular time interval or particular, I would say that particular time in the disease process. So this is what it is. So this is the first trial where the concept of ultra protective lung ventilation was achieved through the ECOR device, and back in 2009. So as you can see that the tidal volume was reduced from 6.3 to 3 almost, and there was no patient related complications. After this is called the extra vent study. If you all probably know that this is being another large ARDS study with use of ECOR devices for reduction of tidal volume. The beauty of these things, I would not beauty, that here they utilize the AB pumpless extracorporeal. So people are not very happy with utilizing the AB pumpless device because the need for atrial cannulation. The good news is that they are able to reduce the tidal volume to 3 ml, but there was no difference between the ventilator-free days at 28 and 60 days. That means it's a negative study. The problem also, notice that there are like high risk of blood transfusion in the trial group in the extra vent study, but this is a small number of people. So coming to the other one, this is called the Supernova Trial group. So there is another, I would say, that prospective semi-RCT trial, moderate to severe ARDS. The goal is same. So they are able to reduce the tidal volume from 6 to 4, but during the course, what they found that there is life-threatening hypoxemia, and then people needed proning as well as ECMO, many of their patients. So this is again, the concept is it is helpful, but it's also practically not possible in all patients. You have to be careful. And this is what our personal experience during this COVID-19, utilizing the ECOR device at the bedside. So, what about the other thing? This is another one from the French group. The same thing. The last, I would say that this is the biggest trial which was published so far. This was being outlined or told by Gunnar at the beginning of my talk. The RACE trial. What is the clinical question? The clinical question is same here. Can low tidal ventilations in patients with moderate to severe ARDS can reduce outcome. So okay, I mute her. So what happened is this is the study from UK, largest, I said, because there are 410 patients, moderate to severe. ECOR was like, the goal was to utilize in the initial 7 days of respiratory failure, the tidal volume goal was 3 ml, and then E-curve was used at least for 48 hours. The problem is it's a negative studies, and then the most important thing you have to learn that the side effect, the trial group 52 versus 23, and most of the side effects are because of the intracranial hemorrhage and infection. This trial was prematurely stopped after 412 patient enrollment because of the risk versus benefit. So that's what's the ARDS practical application and evidence so far. So what about the COPD? Again, the goal here to reduce the endotracheal intubation and possibly to decrease the duration of mechanical ventilation. If you go to the literature or PubMed and search, there are many case series and shows that there is a benefit. But again, these are small series and not I would say that not having the so-called randomized control trial. The only case control study, which is being many times cited, it's called the ECLAIR study, in which there are 25 people with hypercapnic respiratory failure are combined or matched with another 20. And then in that study, they are able to reduce the intubations almost like in half of the period, or more than 60%. In another, like in other COPD utilizations, and particularly other hypercapnic respiratory failure cases, for example, status asthmaticus, and then breast to lung transplant, there are case studies. Even for the status asthmaticus, the latest paper, which is published by Matthew Smith and then Kara Agerstan from New York, they are like 25 to 36, 25 or 30 patients. If you read that paper, to me, to be honest, this is kind of a fake. It's not extracorporeal carbon dioxide removal. Rather, what they utilize on that status asthmaticus patients and then a ECUR paper, which was published last year, is that they utilize the ECMO devices. They have the same cannula as well as the oxygenator. What they reduce is the flow. So I would not call that this is a strong evidence for the benefit of ECUR device in bronchial asthma. However, there are some reports. They are all case series. So the advantage, like the physiological advantage, in addition to decreasing the oxygen, decreasing the carbon dioxide, is it can improve the heart function in COPD patients. So what was being, so this is the study, I just put it there, like, the mean arterial pressures reduces significantly as the PCO2 come down from 95 to 53. And then with that process, there is two things happen. So the way I look into personally, that if I utilize ECUR device in the acute exacerbation of COPD patients, my goal is, in addition to reduce the carbon dioxide, I need to take care of two other things which is potentially problematic at the bedside for my patient. One is, intrinsic PEEP, and then dynamic hyperinflations. So these are the two things which can be potentially avoided if we utilize extracorporeal carbon dioxide removal technology, and then that will facilitate the overall mechanical ventilator strategy at the bedside. The other group where I strongly consider for extracorporeal carbon dioxide removal as a technology is that if the patient doesn't want mechanical, they are DNI, or they do not need intubations, and they just need a comfort, but they are not in the stage that they wanted to be die. And then if you can help them not to go through the death cycle of intubations and then ventilator-induced lung injury, then infections, re-intubations, and death, in that case, it can be helpful. But the timing of intervention is very, very important. I will let towards the latter part, there is a European consensus statement which is published by Alan Coombs and the group last year, is give a very nice cutoff level where we should consider this technology in these people. So the journey, for my personal experience, our group's experience, as well as the studies so far, is that it is scary, but it's worth to look into, because it can be potentially helpful in appropriately selected patients at the bedside. What's the problem? The problem is this, the bleeding. This is again, I just put one there. What was happening is that all these people, those who are put on ECR devices, not only ECR device, particularly VV ECMO, VA ECMO, even if we are becoming smarter to managing the bleeding and thrombosis on these people, we are probably far behind from the optimal state. Particularly my concern on the REST study, if you all know that the intracranial hemorrhage as well as infections and then amount of bleeding. I'm not sure what is the cause. It is because of the smaller cannula, or is it because of the utilization of the heparin or something else? Why? Because the smaller cannula obviously ask for, there is a turbulence and you can require increase your heparin level and that thereby increase the risk of bleeding. For example, utilization of heparin is not really the ideal state. Like in our practice here in Mayo Clinic, Florida, we almost stopped utilizing heparin like in our VV ECMO patient or VA ECMO. Our practice is primarily dependent on bivalvulotin. Why? The paper from our group is already there in critical care medicine last year. It is that what we see that if we are putting on the bivalvulotin, the risk of thrombocytopenia is very, very less. The risk of circuit changes and clotting is very less. The monitoring is less intensive than the heparin-based therapy. So this is what the take home. But again, we don't have a randomized controlled trial to really support one versus other. So what's the next? These are the complications. Again, this is according to the patient, then circuit and mechanical events. So this, this is nothing new. It's probably same as any other extracurricular devices or practice as all of you are doing at your hospital, the VV and VA ECMO. The severity varies, but the theme of higher bleeding rates in extracorporeal carbon dioxide related technology remains to be investigated in a broader and more robust patient populations with different machines, catheter, as well as blood flow rate. That's what the future should be looking into. So the question arises, is extracorporeal carbon dioxide removal is a good option for ARDS? I would say that the answer is yes. However, we do have an alternative, that VV ECMO, because if you can support the patients on VV ECMO, you have the capability, your team is doing the nice job, then I don't think that you need to think about ECR. But if you think that you can potentially reduce the risk of complications, there might be some chances of improved survival, but the answer is not clear right now. What about COPD? Yes, I think if one population where I would really wanted to see the benefit of ECR is the COPD population, because they can definitely be helpful without going to the death cycle of intubations. But what we need to really know that how we can reduce the complication rates, and there are couple of more studies, and then many changes are coming in future with the technology that might help. And then the important thing that whenever we consider for the ECR technology, our goal should be defined from the time zero. Is the ECR is planned for recovery? Is it planned for the bridge to transplant, or is bridge to diagnosis, or what? Because if you are not clear about the goal of bringing the extracorporeal therapy to the bedside, then the ethical issue related to the practice will be very, very difficult. We have faced a couple of them that we put them on ECR, like not here in our sister hospital. Then the question is, they are doing okay, they don't want it to get away from that. You cannot send the patient on home like the mechanical ventilator. They're stuck in the hospital, not a candidate for transplantations. Then what should you do? That's a very difficult situation to face. Role in sepsis, I would say that it's not really needed at this moment. Even the role of ECMO in sepsis remain controversial. So this is what the European expert views or opinion for role of and goals of extracorporeal carbon dioxide in ARDS and COPD. Just remember that the consensus definition focus on that before you initiate, your goal should be like this, driving pressure more than 14 and plateau pressure more than 25. Once you initiate ECUR, particularly for ARDS, to promote ultra protective long ventilations, then target pH should be more than 7.3, respiratory rate should be less than 25, driving pressure should be less than 14, and plateau pressure should be 25. This is an ambitious goal, knowing the fact that the ARDS net trial, which has been the largest trial so far with thousands of people and showing a huge benefit, the plateau pressure is at 30. And then, the driving pressure was not being monitored at that time, but this is a huge ambitious goal. And then for the COPD, it should be winning from the NIV is a mandatory goal in that case, in case you are putting the patients on ECUR. Novel utilizations, one, lung transplantations as a breeze, status asthmaticus, I told you, or COVID-19, again, none of the talk about ECMO or ECUR should be go out saying that COVID-19 has given us the options to extrapolate the benefit of the technology in many patients with ARDS, COPD or combined COPD, as well as ARDS, heart failure, you name it. So more and more people are prospective and case control studies are coming on this, and obviously trauma. Ongoing trial, we are the part of the vent-avoid trial, so which is mainly aiming at a reduction of intubations in patients with those who are coming with acute hypercapnic respiratory failure, predominantly COPD. The problem is the selection criteria or the inclusion criteria is too strict for us, so we are not finding the trial is being prolonged. So hopefully there are some good news. So I can't describe that, but hopefully it will be a nice trial. So with that, the take-home message from my perspective is that ECUR does have a potential to change the future care of acute respiratory failure. However, we are lacking adequately powered clinical trials to support the positive results in favor of utilizing it at a day-to-day basis. For, as I said, it's remain like experimental technology. The most important aspect of the care process is you need to have a multimodal clinical approach, and then the selection is the key. If your selection is wrong from the day or time zero, then it's going to have a bad outcome. So with that, if you all interested to join with our team and learn from us, or maybe learn together, we usually have a ECMO course every year. We suspended back in 2020 because of the COVID. We are back last year, back again this year. Please join or share, and I'll take any questions. Thanks for your attention.
Yeah, thank you, Dr. Pramod. I think it's an excellent talk. It definitely enlightened us. And I think going ahead further, I think ECMO should be one of the standard care of practice in the ICUs. That is what my observation is. And second thing, I'll invite other faculties and panelists. Like I will like to ask Dr. Manish Chauhan, who is a consultant ECMO specialist in FMRI Fortis Hospital, Gurgaon. So hi, Dr. Manish. So my questions to you, like as Dr. Pramod has nicely described the different indications of ECOR. So what is your practice guidelines or your ideology regarding the ECOR? Like provided you have the facility in your ICU for the ECOR, so in which subset of patients you like to use ECOR, like ARDS for ultra protective ventilation, severe COPD for weaning failure or preventing intubation, or weaning from the ventilator, or status asthmaticus, who is presently in crisis?
First of all, this presentation was, I think, encompassed everything that one would think about when one think about extracorporeal therapies, especially ECOR, which is less known and less practiced modality because of the reasons Dr. Pramod mentioned. So similar, I share sort of one thing is that we being an ECMO center for the past 8 years, we are very well experienced in venous ECMOs. So definitely in ARDS patients, we do not prefer ECOR, because if I have a modality which will provide oxygenation and carbon dioxide removal both, with just upsizing the cannula and the flows, plus with not necessarily having the same risk, even, and especially if we are an experience center, I might theorize that the risk of ECMO venovenous might be less than what we might face with a modality like ECOR because of the problems of smaller cannulas, low flows, and higher anticoagulation requirements. So I definitely, if you ask me, I would be comfortable using it for ERDS. For COPD, yes, this is one thing that does cross our mind. We have tried a bit with prisma flexing, but again, lack of data and a lot of unanswered questions will remain there. But if presumptively speaking, yes, I would rather go and use it in a patient of COPD under the ambit of the things Dr. Pramod very nicely mentioned. Obviously, we'll have to take care of patient selection and our aims and objectives, because one thing that is the cornerstone of any extracorporeal therapy is number one is what is your exit strategy. Okay, unless you don't know your exit strategy, it's better उस चक्कर में जाने की जरूरत ही नहीं है. So we need to be very careful about that with the exit strategy and plus the chronicity of the disease. So a lot of questions are there which needs to be answered. Hopefully, the trials might answer some of them for us right now. But yeah, so coming back to the question, ARDS definitely no. I'm more comfortable with venovenous ECMO. I would be looking forward for something in the role of COPD.
And
again,
yeah, please.
So, Dr. Chauhan, you nicely mentioned. I like that, because what you have to really like, you should know your exit strategy before you enter into the ECMO business. Otherwise, you are in trouble. And then that's what it is. And then one of the things I just mentioned is that it has a potential, because it is so simple, intuitively very. You put a dialysis is done in left and right and all issue, the resource constant setting, you don't need anything, and then you have the dialysis machine, you do it. If that can be achieved with this one, believe me, like many people will be benefited. I was personally very disappointed with the REST trial result. I was very optimistic initially that it will be a positive trial, and because when I was at the Euro also, I was talking with Alan Combs and then all the people there and even the therapy. So that, but it's surprised. But if you go deep dive into the REST trial, there are many things they should have done differently. Again, I'm just telling the armchair critics, but doing the trial, and it's how difficult all of us probably know that. But my thing is that the chances of a patient, particularly ARDS, getting benefited by only ECR device in the absence of that you are taking care of oxygenation is a problem, because your oxygenation will remain a huge issue. And then if you are not really happy where you stand, obviously the result will not be in your favor.
Very correct.
And at what point of pH you like to initiate the ECHO? What is your target? Like pH of less than 7.2 or pH of less than 7.1? And what should be your plateau pressure and the driving pressure you aimed at in the patient is in ECHO?
7.1 would be stretching a bit too much. Even I would even prefer even before we reach 7.2. So personally, my heart starts beating if it goes below 7.3. If you ask me personally. So anywhere between 7.2 7.3 is good enough for me. That's the point. I would not want to issue. And the same thing we keep when we think of patients for venovenous ECMO also. One of our criteria is pH also and hemodynamic stability also, along with the PF ratio obviously, and these things. And yeah, plateau pressures anything below 25 is wonderful. Driving pressures as below as 14. I would love to give them, especially the respiratory rate also. All the factors that lead to any form of trauma, you say that electro-baro trauma or whatever trauma we are talking about. So if we have something in the hand where we can handle everything, let's go all out. Why go for moderation? Yes.
And what should be the heparin protocol like? Dr. Pramod described that nowadays they have switched from heparin to bivaloridine. So what is your opinion in this?
Well, personally, we have not used bivalirudin. Only in one case we used because of say form of it, and especially obviously was a VIP patient, so we had to pull all stops out. So this is not easily available, and we have not used it. But yes, heparin, especially in accord, then the heparin dose requirements do go up. But the rule of thumb is the lower the flow of blood, the higher the anticoagulation you have to give. And smaller the cannula, the more turbulence and more anticoagulation that is required. So we definitely would we use heparin and fractionated. Bivalirudin, sorry, we don't have much experience with that.
So I would like to invite my other panelist, Dr. Achilles. So Dr. Achilles.
Thank you, Dr. Gunadhar. I'm very much impressed by the presentation by Dr. Guru. Awesome, fantastic. You made a lot of things crisp and clear to the delegates, and probably all of us are enlightened. I know, we are obsessed with the carbon dioxide here, and we know that ARDS is an oxygenation issue. But when we are dealing with oxygenation issue, we end up with low tidal volume and protective ventilator, carbon dioxide is retained and all that. But studies also have shown, some of the studies have shown that even permissive hypercapnia is not detrimental. Probably it may add a benefit as well, like reducing inflammatory response, peroxide injuries, and a lot of mediators that are released are probably are controlled with the CO2 that is well balanced between 55 to 60 or something like that. But but when we are dealing with hypoxic state and we are having CO2 retention, probably ECOR is the stopgap mechanism there. But how long it has to be continued is still a matter of debate. And as you already pointed out, that we should be able to understand when are we likely to have the exit. We should know the definition, how long we are going to treat the patient. My question is, we are having a lot of problems with anticoagulation. Okay. I would like to ask a few questions to Dr. Subhadeep. Dr. Subhadeep is also a specialist and he has done a lot of work trained in ECMO. When we compare ECMO with ECOR, the main difference is the flow rate. Flow rate. Hemodynamically can we mute the audience? I'm not able to express. Yeah. So basically, the basic difference between ECMO and ECOR is the flow difference. The flow can be acceptable at a rate of around 0.5 liter to 2.5 liters, something like that. So, how comfortable are we? In terms of estimating the anticoagulation. Okay, how do we go about anticoagulating these patients who are on ECMO? Should we use the standard dose of anticoagulation, or should we use little higher doses of anticoagulation, whether heparin or low molecular heparin or bivalirudin? Okay, should we keep the threshold a little higher so that we don't end up with thrombotic complications in these patients? Over to you, Dr. Subhadeep, if you are around.
First of all, thank you, Dr. Achilles, for having this question to me. To answer this question, I think Dr. Pramod has already answered these questions beforehand only, and Dr. Munish has also partly answered this question. In our setting,
we have a lot of problems with the intracranial bleed and intracranial, anticoagulation related complications also. We have ended with bleeding complications. So how do we really keep a threshold, and how should be the optimum anticoagulation, especially in patients with this ECOR and not with the ECMO? That is what I would like to say.
So if we see the existing literature that we have on ECOR, the major limitation of having all the ECOR facilities is the bleeding. If you see the REST UK trial, also the major complications over there was the bleeding. Intracranial bleeding was the major complications, and that was the cause of death, mortality in patients who are actually surviving with other modalities. So obviously, if we compare the ECMO along with the ECOR, ECMO, if we use the very high flow of ECMO, we can use the ECMO even without anticoagulation for even a couple of days also, because especially if we use the very high flow. Even without a systemic anticoagulation, the system might run. But in the setting of ECOR, when we use the low flow and the ultra low flow of ECOR, in that case, you need to have a kind of very high anticoagulation, systemic anticoagulation, and that is the norm. Heparin is the kind of standard of choice. It has been practiced. If you see all the papers that has been published on ECOR, especially the RCTs, the race trials, the currently ongoing is the avoid trials, and all these trials, they have used heparin as a systemic anticoagulation in all those trials. And there are few centers, especially in the patients with a high risk of bleeding, especially pumpless of extracorporeal lung assist device, where they have used veno-arterial device. In that case, especially patients with trauma or traumatic brain injury, sometimes they have tried with a ECOR device without anticoagulation also, but in that case, there's the high risk of circuit clot. Every time the circuit needs to be changed, probably every 24 hours. So especially if we do the PrismaFlex Plus device, probably in that case, if we do not use any anticoagulation, we need to change the circuits very frequently. So systemic anticoagulation is the norm. Heparin is the choice, probably, if you ask me the question, answer the question. But the heparin is contraindicated in the form of heparin resistance or heparin-induced thrombocytopenia. In that cases, probably we can use the direct thrombin inhibitors like bivalvuredin or icdratorban, probably. So that is the in a sense, in our settings, we use the kind of heparin as a kind of standard choice in all patients on, especially on ECMO. In some patients in ECMO, somebody with having a kind of bleeding complications, even we have stopped the heparin for even a couple of days, and then if the system is running at a flow rate of 5 liters, 6 liters per minute, probably it can run probably for a couple of days even without any problems. But ECOR device, we have to have a kind of higher dose of anticoagulation with a titration of the APTT or acidity in a very tighted way.
How do you counteract the bleeding by bivalvuredin? Sometimes because you don't have an antidote for such an.
So that is the problem of using bivalvuredin. So that is the inherent problem of using bivalvuredin. But advantage of bivalvuredin is that it has a very low half-life. So if we stop the bivalvuredin for a couple of hours, probably all the effect of that goes out. Somebody with a renal dysfunction, if somebody with a high bivalvuredin toxicity, we can use dialysis also to counteract the bivalvuredin effect. But most of the time, the bivalvuredin is a fixed dose protocol. We do not have any antidote contrary to the heparin. So that is the major side effect of using bivalvuredin or argatroban as a systemic anticoagulation.
Yeah, thank you.
I think Dr. Pramod will be.
Yeah.
I have one more question. Dr. Sudhi, we have had a lot of discussion about which anticoagulation should be preferred, whether heparin, bivalvuredin, low molecular heparin. I have one question. I mean, if Dr. Pramod Guru is using low molecular heparin in his center, and what is his experience, whether he's using or not using, and why he's not using? I would like to have a little clarification about the anticoagulation protocols.
Yeah, again, so Dr. Ockles, what you are asking is so if somebody among us or maybe the world can fix the problem of anticoagulation in extracorporeal things, well, he or she will win the Nobel Prize next day, I can tell you that. So having said that, what I'm trying to say is that, you know, we have learned from our mistake. Okay, the mistake of utilizing or primarily focusing the practice on heparin is really bad. I would say. When we started our protocol back when I was a fellow and then initially starting at that, we wanted, I'm telling you, if you start bivalvuredin, you know, the reason what Dr. Swarn said that, you know, this is like Dr. Sen said that, you know, it is short half-life. We don't definitely know that there is no antidote, but the way the circuit functions, the way like none of these people, like if I put patient on heparin, 99.9% they will all have thrombocytopenia. There is nothing. It's a very low dose fixed protocol. There is less hassle and it's good. But the problem is that what is the right answer, that how do you monitor? Again, we are, you know, I work in Mayo Clinic, so that's, they don't have it. So we are primarily based on thromboelastogram, you know, take this protocol for the initial couple of days where there is high risk bleeding. Once the patients are going through, or they're like, for example, during the COVID, our average patients, those who are on ECMO, is like 150 days, 200 days, 300 days, you name it. Like, they sit and eat in the ICU till we find a lungs or do something. In that group of patients, we don't do the daily take. If you put them on bivalirudin, it goes very smooth. The problem is, if they bleed, like, we didn't have, to be honest, in my personal experience, in the entire pandemic so far, even before, we don't have any intracranial bleed. I'm kind of surprised to know that the RACE trial has so many intracranial bleed. My past question when it comes that how the hell is the intracranial bleed happens? It doesn't happen to us. So that is something, whether it is the patient populations or the technology or the approach, I do not really know. But to simplify your question, that what should you do at the bedside when you start heparin, be conservative if you are, or if you can possible. Even if
can we use low molecular weight heparin? We know that heparin is probably unpredictable, and has a short half-life. Can we use low molecular weight heparin? Is just a small injection. I mean, you don't have to continuously monitor as well, and it is more reliable as well compared to unfractionated heparin. What do you say about low molecular weight heparin? I'm curious to know about that.
I would not do that. Low molecular heparin, if you give it, you don't have the leg room to do anything if they bleed, because the one in the low molecular heparin, low molecular weight heparin, the chances of retroperitoneal bleed as well as the rectocyst hematoma, they are very, very high. It is a class specific side effect, and in the ECMO patient, you don't want that. That's not there in heparin, so that be careful about that. And then the other one, the low molecular heparin, is the renal dysfunction. If there is a slightest chance, if your GFR is close to 30 or maybe 35, I would be completely against low molecular heparin because the bleeding rates are too high.
Absolutely.
Oh, fantastic, I got that.
Absolutely.
Over to you, Dr.
So either heparin or bivalirudin is the standard of choice. Of course, we have not practiced bivalirudin, but I think it's
I have used bivalirudin, but still I had landed with a bleeding complication and patient died with intracerebral bleed. Even after using bivalirudin, probably I might not have titrated the dose well, or probably I have used very high dose, or there are other problems that might have contributed to intracerebral bleed. But I have used it, but it ended up with bleeding complication.
Yeah, I think let me introduce Dr. Harsh. Dr. Harsh is from the KIMS Hyderabad. They are also one of the largest ECMO center. So, Dr. Harsh, I would like to ask you one or two questions. So, what is, in your opinion, basically the choice of ECOR device matters? Like there are a lot of devices which either pumpless or pumped device. So some futuristic devices are also going to come, like some centers, they prefer to do CRRT along with some kind of oxygenator which can remove the carbon dioxide. So does the choice of device matters, Dr. Harsh?
Yeah. So first of all, like, excellent presentation, Dr. Pramod. Very lucid actually and very comprehensive. Like Dr. Munish said, I belong to the same group. We hardly have any experience with ECOR, okay? But whatever data, whatever literature I've gone through, basically what I understand is it's always between a balance between a right flow and a right membrane area, and you target effective clearance of CO2, basically, to be very precise on that, basically. Okay, so as Dr. Pramod also told, like choosing the right patient and the timely intervention, these two are the other two factors, basically. If you really say choice of devices, what I have gone through and what I know is Dr. Pramod can clarify that part. I think there is no clear consensus on that. What I believe is that ECOR as a technique, it's still in the evolving phase. There are membranes that are still coming up. Basically, it's Prisma lung, there's hemolung CR3, CR4. The membranes are evolving. Now, the techniques of delivering it is evolving. So I think from my end, it's too premature to really say that device has a direct correlation maybe with mortality or the outcomes right now. Dr. Pramod can really enlighten us on that part, basically. Okay, so I think there are a lot of research on the membranes. There are a lot of research models that are being generated right now. So that in the future seems to be very bright. Maybe the right flow. There are systems in which there are low flows, medium flows. They're tried with high flows along with different areas of the membranes. So if you really say the device per se right now, I don't think there's a clear-cut winner right now. We require more ECORs to be done maybe. And as the studies are coming, as Dr. Shivadip also told about the Winter Void, the Supernova, I think as these trials go ahead further, we might have more light on this particular thing, basically. Okay.
Yeah, absolutely.
One short question for Dr. Pramod. Apart from this, I wanted to ask was basically the typical regarding the use of this RRT machine, basically what we call as like the jugaad thing that we do in ECOR, basically. So in a resource deprived setting and the financial constraint, we all of us know that okay, the ECOR circuit, the cost of it and all that. Does maybe a patient, say a COPD patient that you call, who is requiring that has a persistent hypercapnia, can we like, how is the future of that? Can we get away with this kind of setup in which we use a CRRT machine, thread in the cannulas, and maybe what is the future of that? Basically, we did use for one or two of our patients. It looks quite promising in a way in our setup, basically. So this is one of the questions that I had always, basically.
So if you are asking about Prisma lung, it's going to come next year.
You know, I don't know whether you know or not, but you brought up a important topic which is very close to my heart. The reason being, I'm a nephrologist by training. So, this is, yes, the answer is that if you can do it, I personally believe it is possible. If you can ask your so-called here, you know, I am sharing my pain. So I put a protocol and studies for that, the Prisma lung, and then zero bicarbonate bath things, but it got, the IRB didn't really go through for many reasons. So that's, but what I'm trying to say is that, yes, if you can have a zero bicarbonate bath in the dialysis machine, and you can have supply pretty good, and you are at the bedside with your patients, knowing where the blood pressure and how it is going, and you can do the frequent laboratory monitoring, it is possible. And in the, as you said, in the resource constraint setting, that is the future, and it will make a difference, definitely. It may not be, I would say that, the time to get, so getting CO2 down from 90 to 60 may take 48 hours. But the goal is that I'm not worried about that. My goal is that, can I give what is appropriate to the patient at a particular setting without harming? So there where is the issue, and it will do the job. So I am completely in favor, and you should, and whoever is there, if you can convince your people and IRB and the patients, do it. It is possible.
Yeah,
do you have any experience of doing this CRRT machine with neonatal oxygenator?
You can do that. It's pretty good. So the only thing I would advise on the machine, so the setup for, you know, that is the pressure monitoring, just set up the pressure monitoring. Otherwise you cannot do it. It will keep bogging you. Your nurses will be like problematic. Keep it off completely, that pressure monitoring, so that the machine will function pretty well. But it is possible. Yes.
Great.
These are good things. You guys are smart. I love it. Thank you.
I'll just add to the point. Basically, this is another advantage of this kind of setup, because you can avoid the systemic heparinization. You can go with the citrate anticoagulation.
Yes.
So I have one more question. I mean, how sensitivity is when we compared with the ECMO? You know, India being sometimes resource limited, places are definitely there. Not all hospitals are corporatized. How cost effective would it be? What is the place of ECOR in the ICU? over a period of time, when we say around 5 years or 10 years, what do you think the place of ECOR would be? And can we use ECOR in patients with traumatic brain injury along with the ARD? So my question is with both Dr. Sudeep and Dr. Guru, both. If you can answer one by one. Dr. Sudeep, starting with you, and over later on, Dr. Guru can add on.
So Achilles, again, I know probably Dr. Muniz or Harsh or Subdeep can answer, or all of you provide. So I believe, this is again, I said that so at this stage, at 2022, with the current pandemic and with the experience, ECMO should be everywhere. That's the goal, and that should be the practice perspective. The hospital administrator, all the group, those who are practicing, at least critical care medicine or pulmonary medicine or ICU, and that's the goal. The next step of the process is how effectively we can utilize the machine at the bedside. Because remember that back in 1950s, when the ventilator came into the market, so everybody was scratching like, this is nonsense, okay? But see what ventilator has done. So the time has come to us that we as a group, we as a team need to propose that patient can go home with the smaller devices and then sleep there. That's what the future is. The future of ECOR is that it's going to completely change the practice of critical care medicine and hypoxemia, hypercapnia at the bedside. It's the time. So the time is how the machine as well as the cannula can be streamlined to the patient's need. And if we can become smart enough to manage the anticoagulations, we already have the answer. So that's what is the issue is, how to address. Personally, without disclosing the details, there are people working on that, the cannula as well as the tube, which will not need any anticoagulation. If that comes to the market, it's all good. So we achieved our goal.
So probably this is one of the important messages to all our juniors. So by the time they practice the critical care medicine, they should be ready with the training of the ECMOs. And it is one of the going to the standard in the future of ICU in India and abroad also.
Yeah, it will be like dialysis. I can tell you that it's just going to be the dialysis. Like your patient coming on, people are debating right now which patient needs to be on dialysis, whether BUN of 50, BUN of 75, BUN of maybe like 120. This is exactly the same thing will happen. That which patients needs to go to on the respiratory dialysis, is PCO2 of 60 or PCO2 of 90, and who is going to do that? I'm telling you, this is coming.
Correct.
So I really like the passion of Dr. Pramod over there. I am liking it.
So can I make a request? So if our juniors could have the opportunity to go to your centers and have a learning curve there for the ECMO training, so will it be possible from your side to make it facilitate with your team?
Yeah, Gunnar, again, there are some restrictions, but I think it is possible to see what you are doing. You have my email, and then I'm on the Twitter. Please feel free to do. I'll be happy to help at my capacity and whatever the institutional capacity. The goal is that like possibly again, there are some restriction in the absence of so-called USMLE or ECPMG certifications to actively involve in the patient care. However, the possibility of coming and seeing like 3 to 4 weeks or maybe whatever the time frame and what our practice is, the first-hand things is possible. And I can certainly help on that if any of you have any interest in future.
Thank you. Thanks a lot.
And then for your wonderful comment. I don't deserve it, but yes, I think this is what the future is. Thank you so much.
No. I also believe the same thing probably. Only thing we do not practice it much more efficiently or much more vigorously probably in a way you people do over there. Here, always before starting somebody on ECMO, you always think of cost first, because it's extremely no,
Yeah.
it's not like that.
No.
It
It
can be
is,
compared.
it is also for me, it is also for you. So that is why I don't know whether, I hope there is no administrator on the group.
No,
So
no, no.
we need to convince that, this is what the problem is. The healthcare should be at the hand of the physicians, not at the hand of administrator who doesn't know what is the problem. What you are facing is also everybody is facing here, and I am also facing, because you need to convince people that, okay, this is going to work, and then give 1,000 explanations to achieve your goal. That should not be the things. The goal is how we can help the patient which is in front of me, and for which we are all taken oath and then putting our life as well as time in the line. They don't understand. So how can we do that is the next best thing for the future, to promisingly doing the stuff appropriately at the bedside, taking that to the patient as well as administrator, that see, there is a potential, we might fail, everybody knows that we fail. We drive car in the street knowing the fact that the accident will happen and you can die, but nobody questioned that the car maker. But why do they question about this kind of things, like, oh, what will happen if you do that? No, there is a potential, there is a risk for everything. That's my take. So
one more point from my side, similarly, like what Dr. Shivdeep told, similar to that, basically, what I feel is that the COVID scenario has really accelerated the understanding as well. So the problems that we were facing, it is going to smoothen out, because the administrators also understand ECMOs. There are, after COVID, as we have applied ECMO and people have seen the results, especially as a bridging also, plus people have gone for transplants. In our center, they've done a lot of transplants and people have seen the results. So basically, there is awareness in the administration as well. Now there are patients who come for ECMOs, basically. They know about ECMO, and that is very, very, very encouraging in that way, because they come and they are asking themselves that, okay, this is the thing now, do you offer ECMO? So that is really encouraging. That is last 2 years, 1.5, 2 years have really accelerated the process, what I feel. So I think, and with the insurance, insurance and always in the backdrop now, people definitely hiking up that part. So I think we are heading towards good times in which these problems are going to get ironed out overall.
Right. I think one of the questions are from Dr. Deepak. Dr. Deepak is the consultant critical care specialist from Apollo Hospital, Hyderabad. So he's also practicing ECMO. So Dr. Deepak.
Thank you, sir. I'd just like to congratulate Dr. Pramod, excellent lecture. And I think I asked one of my colleagues, that Niranjan, we've done the first sticker in the South India. We had a reasonable experience. I think it was pretty much beneficial for us. थोड़ा ऐसा बोले जुगाड़ कर दिया हमने. But I think what we could find was the selection, as he rightly said, the selection of the case was the main thing. Initially what we found was our center was not that much equipped and trained in the ECMOs. So, but over a period of time in the COVID, I think for whatever the reason, we came to the stage where we know a bit about it. But before that, I think we used it as a transition stage. Jogad, I think one thing I would like to request is, if there's any new developments or if there's anything, I think would like to interact with other people. But for us, I think it was a pretty much useful thing. We could brought out the stiff lungs, especially our criteria was where we are finding the and the ventilator when they're going up abnormally, where we could not do the low tidal volume ventilation. That is where we actually initiated. But I think without ECMO, we could brought out almost, I think, 5 or 6 patients at that time. That's it. That's what I thought I'll share with you.
Yeah, thank you. Thank you, Deepak.
Thank you for sharing.
अच्छा आणि प्रीतम ते बाहेर गेले का मग?
I think now
म्हणजे दोघं जण बाहेर गेले आणि पोरींना सोडून गेले. दोघं नवरा फिरताय मस्त पैकी.
Hi, Dr. Jyoti, can you please mute yourself?
आणि मुली किती मोठ्या आहेत त्याला?
Dr. Jyoti, can you hear? Can you please mute yourself?
No, I don't think.
Okay.
So anyway, Dr. Pramod,
I think so from admin side somebody can mute. Thank you, Gunadhar bhai, for invitation, and thank you, Dr. Pramod, for a nice and lucid presentation. We have done near about 13 acres. So Now, yes, we have done for ARDS patient majorly. Okay, particularly we tried a low tidal volume ventilation, and some of the patients they retain carbon dioxide. Now we had two options: either to go the rate to 30, 34, and 35, and at the end 15, 20 days, 30 days to declare a death. We all know the cause of mortality in ARDS is not hypoxemia; it is the wrong ventilation.
Correct.
So we wanted to take care of that thing. We had two ways. Yes, like my colleague told, initially we didn't have much experience with ECMO, so we wanted to get away with this thing. Yes, we and one of our patient had a intracranial bleed, and subsequently, and another patient we have to change to ECMO. But again, it's a very small experience from our side. We would like to listen from the experts. Yeah, please.
Dr. Niranjan, just let me introduce you. Dr. Niranjan is the leading critical care specialist in Apollo Hospital, Hyderabad, Jubilee Hills. And I think since last 8 years, he's practicing there and he's the ECMO in charge of the Apollo Hospital, Hyderabad.
So if you ask me, Dr. Niranjan, which subset of ARDS patient do you use ECOR at this moment of time? Is it a kind of very severe ARDS or
yes,
a kind of moderate group of ARDS?
No, I think we
population.
Let us say, and both of us, Niranjan and myself, we both practice together. Most of the patients where we practice was when they're going pretty stiff lungs, where hypercapnia is predominating rather than the hypoxemia. And I think most of us, at a stage where they're actually borderline, where they're going up to the very severe stage, and we are left with not a choice of ECMO to the extreme. At the other side, or else maybe a contraindications to the ECMO, those kind of things, right, Niru?
Yeah. That's.
So basically, we are organizing such sessions, interactive sessions almost every week. So I'll request both of you to share this link among your DNB fellows and colleagues, and let's have such academic meet and some interactive sessions with you also in the future.
Niranjan and Dr. Deepak, what you both have to share is, I think it's a very good teaching point and learning point from your experience, as Subhadeep asked that. Remember that, for example, we do tried like one of our patients. So I did pull the trigger because of the, even knowing the fact that we ran out of our machine. This guy was 43, the lungs were completely stiff with 2 chest tubes, morning failed, and then paralyzed fell, and there is nothing. He was almost dying, literally dying. The pH is like astoundingly bad, like inotropic support, that you name it. So I didn't have any option, but the guy was 40 something. So then I pulled the triggers to at least buy 24-hour time to get these things under control till I find the machine. And he did well. Like, this is a wonderful, successful story because, for initial 12 hours, we were able to reduce the need, and the CO2 has been taken care by the entire void. And then the next day we went into the VV ECMO. So ultimately he was on like days and got the transplantations and got. But what you are really mentioned, Niranjan and Deepak, is important. In the ARDS populations, if you can diagnose or we convince at the bedside that your lungs are stiff like hell, okay, you get the CT scan, your compliance is too bad, and you don't have any other option. You keep rising your respiratory rate like 30, the driving pressure is hitting like roof, and then the plateau, and then you don't have any option. If you can bring this, even if it will not give you the optimal state of oxygenation hypercarbon dioxide, but there is just a time. If you give them a couple of days, then something happens. Let's say their diet is okay, or the healing process improves. There might be a good outcome, to be honest, because I don't know what you guys experience. I am completely against the idea of that ARDS patients should be considered as fibrotic stage after 4 to 6 weeks. It's not. That 4 to 6 weeks is completely beyond, like, we have our patients, those who are on like almost dead for 8 weeks, 9 weeks, like, and then they come out of complete lungs clear and goes home. One of the patients, I'm surprised. Again, I would say that the N is 1, but the N1 has something. The lady was put on ECMO for 108 80 days with all fibrotic lungs and then sitting on the ICU. We could not able to transplant because she was positive. Finally, she recovered. She went home on the trach and then she's doing fine. So if we apply the traditional teaching which has been written that 4 to 8 weeks is the ceiling time where the chances of recovery from the ARDS patient is going to be completely zero, is not, because it is, we don't know the potential of recovery of the lungs. If you have the capability, if you can support, and it's just single organ dysfunction, keep continuing the approach. There is no question about that.
Absolutely, absolutely right. And what is your take on the lung transplantation on the patient on ECOR with ECOR or ECMO? So can you share the experience?
So I'll say two things. For the ECOR, I still believe that if it is a hypercapnic respiratory failure, if they are, personally, I am interested to put them, these like particularly cystic fibrosis or ILD patients coming with hypercapnic respiratory, I hate them to intubate. If I can put them on ECOR and they remain fine, it will be a good segue for transplantation. Why? Because you are preserving their functional status, they are talking, they are participating in the overall process, and then the side effect related to the ventilation is gone. So they are the best candidate. Right now, one, we don't have a lot of machine, and then it's not approved. And then the only center which has shared their story so far is from Vienna with 25 or 15 patients. So this is another potential area where the ECOR will do a pretty good job. The other one, as you said, that, how do you do, like, let's say you intubate the patient or you put the lung transplant initially, there are few people, like, there is a donor to chest mismatch. So the lungs are high or small. So there is a subgroup of people, those who are after transplantation, they don't have hypoxemia, they become hypercapnic. And then in that case, in the post-op period, you can really help them for longer time till the lungs recover. So this is, I'm sharing the personal experience that we need the device more frequently to be utilized, but we are limited because there is not much data and people are questioning, like people keep questioning about ECMO, like why you're doing, and then all that stuff. Everybody on ECMO dies. But as Deepak said and Swarna said and Dr. Muniz, so the wave is in favor of ECMO right now. There's no question from all levels. So this is good.
So I have just one query from my side. In your experience in your center, to use a ECOR device in hypercapnic respiratory failure, how long you put them on ECOR device? What is the kind of timeline, median timeline, like for 2 days, 7 days? So what is the kind of median time frame they keep on requiring ECOR?
Yeah, that's a very good question. To be honest, like, it's all depends upon the cause. If you have a idiopathic cause or use the unknown cause of acute hypercapnic respiratory failure in a COPD, and then who is not on oxygen therapy at home, you think about probably 3 to 4 days, 48 to 72 hours, it will come out, because you give the steroids, the dynamic inflammation gone, the inflammation comes down, then we'll be fine. However, if they are on home oxygen and then, the inflammatory component is a little bit higher, or you don't know, or there is undiagnosed ILD, then you are in trouble. So they will not come out. So you have to be prepared for, I would say that in average, you should be thinking about 5 to 7 days. That's the time limit. So that's where you can go one versus other way.
So before that, we need to have a kind of exit plan.
I mean, the exit plan before even you think about, go and talk to the family that listen, I'm trying this because of XYZ reason, then if that doesn't happen. So what I'm trying to proposing right now, even I was not able to successful, the decisions to stop and initiate ECMO should be on the physician group. Do not give it to the patients and family. It's going to be a mess, because if you do that from the get-go, take them to confidence that, okay, we are trying to give you the maximum benefit. If we fail, we'll stop in our discrimination. You cannot tell us to when to stop or not, because these people are talking, like you can't just go and say that, okay, this is not working and then stop. They will say that, like, we have been facing that thing. So they'll say that, like, no, just continue the machine, we'll sitting here. Yes, if the insurance is paying, I don't have any problem. The hospital is happy, I'm happy. But if the insurance is not paying, then it's my headache, and everybody's headache.
Yeah, I think with the lack of time, I think let's wind up the discussion. And definitely it is a very wonderful session. I really thank Dr. Guru and all the panelists, all the delegates, all my students and other intensivists, Dr. Deepak, Dr. Niranjan. And I think let's carry such sessions forward. And in the future also, let's let be a pro ECMO intensivist and develop the ECMO care in India. That is what is my take-home messages today.
Yeah, maybe Dr. Guru might be able to help us a lot in this process.
And
I'm happy to have
we should also stick to the basics. Let us try our ARSNet protocol first. Any hypercapnic is coming. If this patient is there with you, try your basic stuff first, because if you have not tried it optimally and just switching over to these devices may not be justified. Use your optimum peak, like Dr. Guru has told us. We underuse peak. We hardly use peak of 10, 12. Can't we go up to 16? Monitor driving pressure. Sometimes a patient may be accepting a higher driving pressure also. Transmural pressure, esophageal catheter, if you have, we can use that also. We can use lung ultrasound for recruitment, de-recruitment assessment, and then if everything is failed, use ECMO as a bridge therapy. But you should be able to understand how long you're going to use it. Use it optimally with all the resources, with the best possible support, taking into consideration the infection control that is associated, which is of paramount importance, and do your best on anticoagulation therapy. The complications, like bleeding complications, are the ones which are very lethal, and we have to lose the patient. So we have to have the better understanding of the pathophysiology, try your basics, and then go for these devices. But before switching to these devices, also we need to have a good understanding of ECMO.
And the most important is you should have an ECMO team or ECMO team in your hospital. With a good
they should always try a proning, as I think that Raklesh was telling. Yes, they always forget proning, go for the extracorporeals many times.
Yes. And the administration backup is also very, very important, of course. So you should always coordinate with, at least in India, the administration, not to forget their role in such kind of cases, because the stay is prolonged, the cost is huge, the mortality is very high, and everybody needs to be counseled for that. So that is the one important thing. And I would also like to thank Misbah. Misbah is our coordinator, basically. She has arranged this whole program on the Zoom. So Misbah, you are there?
Yes, sir.
So thank you, and thanks to Misbah and her team. So let's wind up.
Yeah. Thank you. Thanks, everyone.
Thank you, everyone.
Thank you, everybody. Thank you. It's a very nice interaction.